Hi, everyone. Welcome. This is a webinar by Wonka Africa, Afro-PHC, and WHO. We're really grateful that you've all joined us. I'm very grateful that Edward Chagonda, who's from the College of Primary Care Physicians in Zimbabwe, has joined us and is willing to share. I just want to quickly mute something, but what I'd like you to be aware of, and before we get started, is how the platform works. I just also will share quickly some of the, sorry, give me a second. I think my computer's crashing on me. So I'm going to just go to some data that is available on where Africa sits in the sort of spectrum of COVID right now. I'll share with you my screen, and there's a very useful website that I usually check on called africanarguments.org. And in it, it actually has your confirmed cases in Africa. And you can see it's almost 350,000 cases in Africa, and that's a growing number. And I'll show you another graph right now. But you can see very usefully from this where the hotspots are, where the epidemic is actually flaring up quite substantially. And you can see that it's in South Africa quite strongly, but growing in Nigeria, Ghana, and some of those places. So this is exactly the concern, that as we progress, this is going to grow. And I think it's very useful that we can share some of the insights across the continent in preparation for what might eventually become quite widespread. So as you can see on my screen, this also allows us to pick up on different countries. You can see Zimbabwe basically has cases of about 525 and about 6 deaths. And that is where it sits right now. And I think what's really important is what is the trajectory in Zimbabwe. I think Dr. Chagonda will share with us what this means, exactly what happened towards the end of end of May, to create this sudden escalation in numbers, probably the stopping of a lockdown. So with that, I think giving you an idea of where Zimbabwe sits and how things look across the continent, we can get into conversation with Dr. Chagonda. Let us start by just welcoming Dr. Chagonda. Thank you, Edward. Perhaps you wouldn't mind introducing yourself, Edward, briefly, your background. I'm going to just quickly stop the sharing so that we can see you. Edward, do you mind sharing your background and your place of work, and also your position in Zimbabwe?
Thank you. My background basically is we are speaking. I am the immediate past president of the College of Primary Healthcare Physicians of Zimbabwe. I'm a registered specialist family physician who was trained in South Africa at Stellenbosch. And I'm currently also a lecturer at the University of Zimbabwe. We are just starting a program in family medicine. And I hold a couple of other portfolios all over the country. Yeah.
Nice. Do you mind sharing? You seem to be in your practice. So are you practicing in your practice privately?
Yes, I practice privately in my practice.
And whereabouts is that?
In the high density area of Ziwarasekwa. It's right in the center of in a township in Harare. It's one of the biggest townships in Harare. That's where I'm practicing.
Great. Well, thank you for that little bit of background sharing. Can I ask, apart from the picture that I showed you about Zimbabwe, can you share with us what's happening in terms of the epidemic and how it's been progressing within Zimbabwe?
Basically, as you can see, the curve was nice and flat beginning. We started our lockdown in March, on the 30th of March until June. We didn't have much happening really. Then I think what has been happening is our borders, our next door neighbor, South Africa. We have lots of Zimbabweans who are in South Africa, and they are coming back. So that really explains more than the 432 to be specific, have come from South Africa. So it's really important figure. And these are our citizens who are coming back to our country. They are all in quarantine, and we will see how it pans out. We are trying as much as possible to put them in quarantine for the specific period until they have recovered.
Okay. So in terms of the government response initially, when the cases started, being a landlocked country, they basically went into lockdown. What was that like? Can you tell us what happened then?
Oh, it was a total lockdown, really. All of us, even I closed my shop here. Many, I think, over 60% of the practices in town, in the country, were closed. It was really a total a lockdown. There was no movement of people and everything. But with time, we went into a second phase. There was a reassessment, and the figures were not going down, as you can see on the curve. So there was a little bit of relaxation, but still, that does not explain these guys who are coming back from outside the country, and we cannot block our citizens from coming back. So really, that's how it feels. There's been a little bit of relaxation of the lockdown, and there's fatigue in our population. That it's quite a long period now, going to nearly 4 months, and people are really, there's not, which has been happening because the figures were way below 50. So you can imagine, in a country with nearly 15 million people, we have only 50 people who are afflicted, and you see that the attitude is that there is really not much happening.
True. Yeah, it's the challenge with trying to contain it. When you succeed, people feel you've been too harsh in containing it.
Exactly.
Yeah. So what has been the challenge that people are fatigued by? I mean, you've closed voluntarily. Did you find that public health facilities were shut down, primary care especially? Were those clinics and public services for primary care shut down as well?
Our primary care facilities, most of them, the public ones, did not shut down. None of them shut down, really. It was really, the main issue was to do with the availability of PPEs. That was the main, the protective clothing, the protective equipment. Everyone was rushing for those, and the biggest problem was that the prices, when they got in, being a landlocked country, the prices were just something else. You can think of gloves. They were costing about $5 American. They shot up to nearly $10 American per 100 examination gloves. That's, and everything else, just went up astronomically because of the demand which came up. So those were the major challenges. But the public institutions remained open, and luckily we did not have a average of anything because we did not have any cases anywhere. The prevalence was very low.
Did it affect, almost the social determinants of health? I mean, the impact of the lockdown. What has that been on people's livelihoods and, their health generally, other diseases? Has that been affected? The lockdown has an impact.
Yes, this would be anecdotal. We are yet to do a real study. We are doing that through the Department of Community Medicine and the city of Harare. We want to determine really if people tended to stay at home, even with all other diseases. The numbers at all public institutions went down, I think, to less than a third. So it's really someone who has a very serious life-threatening disease who then dares to go to hospital. Everyone was kind of scared to go to and to visit any institution. And as we speak, up to now, even in the colleagues who have got private practices, the figures have really gone down, and they are not up, because people are afraid of getting the disease also from the institutions.
True, true.
Yeah.
So what has, and you've said that, in fact, patients are not even visiting private doctors. What sort of drop in percentage do you think is happening amongst people in terms of visits to clinic? Is it half or a quarter or a three-quarter drop?
I think the drop really is more than 50%.
Right, so it's quite
There's a
substantial.
more than 50% drop, yeah. So it's quite a very significant drop, and one would think maybe we have kind of adopted telemedicine. Most of my patients, most of colleagues, we have said the approach is, if they can phone us, then try to give a prescription over the phone.
Right.
And then if things don't go well, then they can then visit. And when they visit, you do all the precautions, face mask, you are well prepared to see the patient, and you have taken the history of the patient. Right. So that's very important what we are doing. And I think, yeah.
So you're saying that a lot of the doctors, that's private doctors, GPs, are actually adopting that approach of using the telephone.
Yes, yeah, we haven't come up with a tariff as yet, Prof, of how much we are supposed to charge, but we are just negotiating with patients, and really people are adopting telemedicine. Even our council, the Medicine and Dental Practitioners Council, has advocated for telemedicine to be in place now. No, generally, I am a little bit from the old school. I never thought to do telemedicine, but we are changing with time, and we are looking at telemedicine as a reality, really.
So you're using the telephone. Do you use the internet? Is the internet quality of good, or other than telephone? Are you using WhatsApp? How are you actually using the telephone or internet? Just
I'm most of the time, Prof, it's just a telephone, not
like the ordinary telephone.
The ordinary telephone. We are not using the video calls, but yes, you can see I'm using my phone now, and with our network, so it's fairly very good network, I must say. Yes. So it works very well.
The challenge is perhaps with patients having access to phones like yours. Is that a challenge? Do you think people are having phones where they could use the internet and video? Just a curiosity.
Yeah, no, that's a big challenge, and it's something which is worth really studying as well.
It's an important lesson that, in fact, you've resorted to measures, but the technology is limiting your capacity to go down that road. Well, that sounds interesting. So, in terms of lockdown, most governments have said we need to use the lockdown to prepare. What's going on in your both the public and the private sector? Perhaps we could start about your insight on the public service. Have they done things to prepare? What has changed? What's happening in the public service to prepare for this upsurge?
Absolutely. There is a lot of which has happened. In the beginning, there was not much happening. Really, people thought we were prepared, and we had a real disaster in the first place, because the first cases, those 4 deaths which occurred earlier, those were all patients who just came and they really just died with the comorbidities, and they died, and everyone was really panicky that we are not ready. And that's the time when in the Italy, in the UK, in Spain, when we had lots of people dying from acute adult respiratory syndrome, and people needed ventilators, and there was a lot of talk about ventilators, the expenses involved, and that everyone may then need a ventilator and things like that. So it was really a very difficult period for the government and for us. We are not very economically endowed like most countries. We are having our own problems here, and it has been a real challenge that the health system was suffering a little bit. And now this COVID is putting a bigger burden on the already strained health sector. So what they've done is they've created, the government has created 2 central hospitals, one in Bulawayo, one in Harare, to become COVID centers, just in case. So there's Perinatal Hospital and United Bulawayo Hospital in Bulawayo, which are dedicated for COVID.
Right.
And they are not admitting anyone else. They are only admitting COVID cases.
So what's happening to their cases that they wouldn't admit, the normal cases? Are they being rerouted?
No, for now.
Sorry, Edward. Ouch. So we seem to have, I hope Edward comes back on. Yes, Edward, we missed you a bit, but carry on. You said that the cases are being what is happening with the cases that are not COVID? What's happening with them?
There are other hospitals, as you can see, as I said, that
So these are hospitals that are
doing is
okay. So these are.
Pardon?
Sorry, no, we're missing you a bit.
Because
I
of
think
the
yeah. So the bandwidth's shifting slightly, but so you say the other hospitals that they're being referred to.
Yeah, yes. The other hospitals are quite functioning normally, like the Harare Central Hospital and the Mopilo Central Hospital. They are functioning perfectly normally, and they are not admitting anyone else.
Okay, okay. Well, that's useful.
All COVID cases and the other facilities in Harare, where the infectious disease hospital, like the Beatrice Infectious Disease Hospital, and we have got Wilkins Infectious Disease Hospital, same in Bulawayo, and around all the provinces, we have various facilities to take.
Sorry, Edward. Sorry, Edward, we missed you a little bit. So, Edward,
sorry.
Just tell me. No, it's fine. Don't worry. So, Edward, tell me, in terms of primary care, how have you all, responded in primary care, public services, and then maybe you can talk about private as you are in. How are you all actually adapting to the new situation? What are you all doing to prepare or to deal with it? So perhaps you can talk about the public service.
The public service, as I've said, is they've structured that there are various facilities which are totally different. There's one to deal with non-COVID cases, and another line to deal with COVID cases.
Is that only hospitals, or is that even primary care clinics?
Or even the primary care clinics as well.
Oh, so they've created that COVID clinics in the community.
Yes. If you go to the community, there are tents where everyone is screened before. So they say this is COVID or non-COVID. So there are screens at all primary care facilities.
So say that again. So you say there are, when a patient goes to any clinic anywhere in the country, there's a screening process.
Yes.
And that they when they screen, if they have any symptoms of COVID, they are referred to those COVID centers.
Sure.
Okay. So what sort of screening tool, what sort of questions do you all use to screen patients?
So the basic is like fever, shortness of breath, flu-like symptoms, travel, contacts, and things like that. That's what they really look at.
Okay. When you look at the sort of way in which current clinic services are running, so if a patient comes to the clinic and they have these COVID symptoms, what do they tell patients? Okay, you must jump back in a taxi, or are they having a separate area, or are they taking their own transport, or do you transport them to that COVID center that you
Once
mentioned?
yeah, thank you. Once they have been identified as people who are likely to have COVID, then there is a COVID reaction team, which then comes, picks them up, and then also, if depending on the results, when they are then tested, they'll then have to follow up each and every contact who has come. If they come in a taxi, that person will have to be screened and quarantined as well.
Right.
Before only yesterday, what we were doing was people would be quarantined or would be put into self-quarantine at home. That has changed as of yesterday. People are not behaving very well at home, so they are now being quarantined in a quarantine center. So the laws have just been repealed and changed. The rules have changed as of yesterday because of indiscipline. We are having a few. We have, I think, about 50 local transmissions, and that's quite worrisome because people are being mischievous at home. They've been seen going to shops to buy and things like that. Are not really self-quarantine.
Yeah, that's difficult. So when you have this situation of patients who are positive, you say you're now saying they must quarantine. What's the turnaround time for patients at a clinic or at one of these centers to get tested? How is that working in the country, testing?
Yeah, obviously we've got to, if it is a suspicion of COVID, people go through the PCR testing, and we are using machines, gene expert machines, which are found everywhere in the country now, and we have got reagents for them. So the turnaround time should be about 24 hours. Really.
Well done. If that's happening, that's really good.
Yeah.
Well, that makes it very much easier then for you to then pick up patients who have symptoms, test them, and then follow up contacts and quarantine them.
Sure.
Hopefully that is how you manage it, and it sort of keeps it in place. When you have these situations, like you said, 50 people that are popping up in local community transmission, have those people been in any of them been primary care workers, people from the clinics themselves having COVID?
Yeah, we have seen only about 3 to 10, I think, about 10.
Right, so it's
not that big. 3 of them have been guards at a quarantine center. They're actually guards at a quarantine center who turned out to have a COVID.
Right. But not in the clinics, in the communities where local transmission has occurred.
No, not in the clinics, not yet. They are from central hospitals.
Right. Okay. So has there been baseline testing of staff at facilities, perhaps even starting with hotspots in the community, or is that not evident as hotspots in the community? Are there any hotspots, places where local transmissions occurring?
Yeah, what we have done is what was happening is almost if there's any occurrence, like the first few cases, we would mop up the whole area would be tested. And as we are speaking, most of the guys who are coming in almost on a daily basis are from South Africa, I must say, the majority of them, and they are in quarantine. Okay. And really, we are strengthening what we can do quarantine, which is very important, so that these guys who come with COVID will go through the disease and they can go into the community when they are sort of free from the disease, from infected.
No, that's true, and that actually, is probably the way we should all have done right at the beginning, is control our borders very strongly before we allow people to kind of come in. So at the moment, what is going on at the borders? I imagine that all borders, wherever there's some movement, what is the process that you all are doing to screen patients? are you going through the same sort of symptoms screening, and then everyone gets tested and then forced into quarantine or until results are back? How is it working?
Yeah, everyone who comes in has got to be quarantined, and
Right.
they are tested on day 8 in quarantine.
Oh, right. So you're testing them day 8, and then after that, if they come out negative, they go home.
They go,
Otherwise,
we were saying they go home for another 2 weeks in self-quarantine,
at
but now
home.
it's already changed. So
Okay.
they will have to be staying much longer until, and be tested regularly. You know that the turnaround time for the rapid test is about 7 to 10 days. So that's why the figure of 7 to come up, that we test on day 8, and if they are fine, then they can go home. Then they are tested again a week later, and then but they will be at home, quarantined from home. But now we found that that's very tricky. So people are going to be staying a little bit longer.
Okay. No, that's fine. Well, I'm not sure if you've got any other comments to make, but I think we've got a reasonable idea of what is going on in there. Tell me what's going on in the private sector. I mean, even your own practice as an example of how
Yes.
things are working in your setting or other GPs in primary care. How is it affecting you or other GPs?
Yeah, well, everyone is crying because the figures have gone down. If your
Mm,
revenue has gone down by 50%, you can
true.
imagine what is happening here.
Yeah.
So really, it's a different situation, and with a very expensive situation as well, because you have got to put on a protective clothing all the time.
Yeah.
And everyone, your nurses, the reception staff,
Yeah.
there's a lot of more chemicals being used well, for sterilizing and things like that. So
Yes.
I must say it's a different era. It's more expensive to run practices, and I think people have got to rethink about how to run, especially single man practices.
Yes.
They've got to think twice, and they
Yeah.
think of maybe group practices, which may be a better thing. I think in South Africa it's a better arrangement of group practice. Here, where we have not been practicing as groups, and it's really taxing on one person if your revenue has gone down that much, and the numbers have gone down
Yeah.
quite a lot. And to couple that, we have had quite a serious economic recession as well, which has
Yes.
been happening. So here things are very tricky as we speak.
Yeah. Yeah. I think it is, lots of places in Africa, same problem. So in terms of you as like you said, most GPs closed down, almost 60% in lockdown. Now that they've opened, that they mostly are finding half their practice sort of turnover or patient burden than before. What percentage are using telemedicine? If you were to, based on your conversations with friends and yourself, what sort of about plus minus are actually turning to telephones to practice?
I must say, before we reopened, we kind of before June,
Uh-huh.
almost I would say 80%, but that has gone down again. And I think it's a culture which is in
Yeah.
people. People do not believe, even our patients, they don't
Uh-huh.
believe in telemedicine. Our
Yeah.
patients are used to see the doctor. They want
Yeah.
us to feel, listen, feel, look at each other.
Sure. Yeah.
That's what they want. If
You
you
touch
don't touch
them.
the patient, then they are not happy.
It's true.
So
It's true.
it's a culture which has to change.
Mhm. So you said it was, from 80%. Is it now much less, or it's gone away
Yes.
completely?
Anecdotally, it has gone down maybe to about 20%.
20%. So that means that 80% of the doctors, or 80% of the time, doctors are seeing patients, in person. How are they organizing themselves in their practice? What are they doing to manage, besides, the PPE of staff? Are there any other things, I mean, that you could say, well, I'm organizing my practice in a particular way?
It's difficult to do it. It has been quite difficult because how the practices have been set up is tricky. It's like you go. It's not a unidirectional flow, because ideally we should have unidirectional flow. We should have waiting areas. We have barely just a waiting area, maybe here, which is about 30 square meters. And what we have been doing is to restrict the number of patients coming in. You only want one patient, and if they can walk, if they can do things unassisted, you want one person at a time in the practice. And then you deal with that person. Once you are done with them, then they go out. We don't have a kind of a laminar flow of patients because of the design of most of the practices. But ideally, we should have a kind of a laminar.
Sorry, Edward. I hope you can join us. So, Edward, you say you've actually limited the number of people in the practice itself.
In the practice, yes.
So at the door, you are actually telling people, please wait outside.
Wait outside.
And are you checking on what's going on outside? Have you organized it outside, or you just say wait outside?
They wait outside in their cars.
In their cars. Okay, so they wait, and then you call them in one by one.
One by one.
One by one. So you are basically having all staff members wearing PPE. What sort of PPE have you used in your, let's take your receptionist and your nurse and yourself. Do you want to tell us what they wear?
They just put in a face mask and just a normal mask, a face shield and a mask.
So the visor and a surgical mask or a fabric mask?
A surgical mask.
Surgical mask. So your receptionist has that. What does your nurse? Your nurse also has similarly?
The same thing.
And you as well?
Yes, and me as well.
Okay, so that's basically your PPE, surgical mask and visor.
Yes.
Okay. Do patients wear fabric masks? Is that something that the country has decided to encourage or mandate, fabric masks?
It's mandatory that all patients, everyone has got to put on a mask.
Right.
And at my practice here, when they come in, they have to put on surgical masks.
Okay, you mean you issue them surgical masks?
I issue them with surgical masks.
Right. Okay.
At my practice, so that they don't have to be putting on the fabric masks because of the rate of transmissibility. That the surgical 3-ply surgical mask is a little bit much better in terms of prevention of the COVID disease.
Okay. And do you screen them in the practice itself, like a receptionist or as a nurse, before they see you to see, okay, have anyone got COVID symptoms, or how do you manage that? Or do you do that?
We do that. That's what we do. If they have the really florid COVID symptoms, we try to usually triage them to the COVID centers. So we are using.
Okay, so you carry on. So you do that, outside or inside at the reception?
While you're outside, they don't come inside.
Oh, so you actually have someone going to each person waiting outside and asking them these symptoms.
Exactly.
And if they have any of those symptoms, you say, no, you have to go to that.
You have to go to the COVID center.
Okay, interesting. So you're at least managing that problem potentially of COVID symptoms.
But that does not preclude that, we can have people
asymptomatic.
Asymptomatic. They can always come in. Yeah, so it's quite tricky.
No, true. So when the patient comes in, one of the big problems is to think about the sort of sanitizing hands and making sure that people don't touch surfaces. I mean, for example, where do patients sit when they come in, and how do you manage that surface?
The surface, what we do is you sanitize them, After sanitizing them, after they've finished the paperwork, what we do, is they don't touch the cards at all, and the money, you touch it using gloves. Then you change the gloves, you put it in a safe. You don't touch the money, and I only give them my prescription. After I've written the prescription, I write the card. The cards are brought in by the sister. The nursing, the receptionist brings in the card. The patient is not allowed to touch the card, and I open the doors for them. So they don't open doors, they don't do anything. I just open doors for them. They come and sit. After they have sat down, when they leave, we sanitize the whole place again. I've got a spray sanitizer when they've left. Yeah. And
well, that sounds really good.
Even if they
really
go onto the couch, you also sanitize the couch as well.
Yeah.
That sounds fair, but I don't know how effective that is.
Well, couches are hard to clean. That's the problem. So maybe better to have plastic chairs so you can clean them better. But that sounds like
the couch is plastic. We have everything is in plastic.
Right.
So it's the regulations in Zimbabwe are that all rooms, doctors' rooms, have got to have washable and cleanable surfaces. That has been a standing rule.
Well, that sounds really good because that saves you a lot of trouble before COVID. Well done. Well, let's see if there are any questions. Thank you very much, Edward. I think the one question that John Musonda asked about, what % of doctors using telemedicine, I think you've mentioned that, that it was 80% and dropped to 20% now, and mostly, telephone rather than internet-based, questions. I think that's the one that we've answered already. I'm not sure if there are any other questions from any of our participants, or if anyone would like to speak. I see Colin Goldberg. Would you like to speak? You're free to respond if you like, Colin. I can unmute you if you like, and you can go ahead and speak. Colin?
The problem for me is about the education of the general public, because I notice in my own backyard there's poor compliance by a lot of people in various communities.
So, Colin, do you mind just telling us, Colin, quickly where you're from so that we just have a bit better context for you?
I'm from Cape Town.
Cape Town. Okay, well, we'd love to get a little bit more from you about what's going on there. But your question is basically, what about community education? In other words, Edward, what is going on in the community about those preventive measures? Are people wearing masks? Are people washing hands? Are they keeping distance? What's going on when you walk around in the township or drive around?
Yeah, well, let me be very honest with you. There's a lot of community education. Education everywhere, but I think people's habits are very difficult to change. You find that everyone is putting on a mask, but it's only covers the chin or it's in the neck.
Yeah.
Everybody, almost. I'm running a little survey where I want to get to maybe 100,000 people, and then they just publish that if they are wearing masks or not. Yeah. It's terrible. More than 80 to 90% are not wearing those masks. It's just wearing them for the sake of the police, because there's police everywhere. So the community is not really understanding what we are talking about.
And what about distancing? I mean, are you seeing lines where there are 1.5 meters apart in all these public spaces or taxis and buses? Are they managing the numbers inside?
No, they are not. They are not. That is not happening. You see people in a bank queue, they are only less than 1 meter apart. Sometimes they are even touching each other. People are not really following what the ministry or the government is saying. People are not following it. It's quite a tragedy, really. But maybe we are lucky that the gods are saving us for now. But people are not following what they are being told to do.
Well, it's showing up in the numbers just climbing. I mean, is that, Colin, what's happening in the Western Cape, in Cape Town?
Yes, it's increasing.
Yeah, it's kind of spiking quite wildly. So
and also what I do is I check the COVID stats every day on the internet.
Yes.
And then one other problem is that some people, when they wear the mask, it steams up their glasses and then they fall.
Yeah. It's true. I mean, mask wearing is, encouraged, but it's not mandatory. And then when it is, it's rather hard to actually, do anything about it. So it's a real culture, like you say. What's the culture of people? And we really have to think, how do we actually get that happening on the ground? So, Colin, just a quick question from your background. I hope others wouldn't mind just asking some questions or even making some comments and adding you can speak if you wish. So, Colin, do you want to share with us, we're planning a webinar next week for the Western Cape. But if you don't mind sharing quickly, I think even everyone around Africa would love to know what's going on in Cape Town. And if you're a GP, what are you doing differently to what Edward is doing? Or how are things panning out in your practice? You want to share?
Yeah, I'm not having much exposure at the moment with the COVID at the moment.
Right.
So I can't really comment much.
What is you're a GP?
Other than to get people to be a bit more compliant.
Okay. So you from Cape Town, but you mind sharing a little bit of background so that we could just see if you could help us understand a few things. Your background in Cape Town?
No, I'm in Cape Town. I'm based in Cape Town.
A GP?
No, I'm more in the emergency field.
Oh, all right. And you say you're not on the ground at the moment to sort of speak to that?
No. The few people that I do speak to, I do try to educate them and explain to them.
Okay. All right. Well, thank you, Colin. Appreciate you sharing some views. What's it happening like in the community there in Cape Town? Apart from the fact that, I mean, do you think that people are more conscious in Cape Town because the number of deaths are high?
Let's put it this way:
4,000 now.
Yeah, in the more affluent areas, there's better compliance, but in the lower socioeconomic areas, you battle with the issue of compliance due to the social dynamics and also the adverse conditions that people are living under.
Of course. So, I mean, in Cape Town, I think you're seeing around 4,000 or 5,000 deaths already, almost 60% of the country total, isn't it?
Yeah, and it's affecting people from all socioeconomic classes, from the rich to the very poor.
Yeah. So one of the things that crossed my head when Edward was talking about is that, until people see the reality of, hey, hang on, somebody I know died or got really sick, that's when it kind of rings home that, hey, you know what, I could be one of them. And that's the culture shift we need. But how do you get it across to people when, they don't see the death? Sometimes it just looks too remote for them. Is that shifting in Cape Town?
Not yet, but if you look at the more educated people, the people living in better areas, they are more serious about this COVID, and they follow the isolation to the letter.
Right.
But the people that are more sociologically or economically disadvantaged, they become very, very poor
compliant.
Yeah.
That's fine. It's always a challenge. Any comments? Thank you, Colin. Appreciate you sharing a little bit of your experience in Cape Town. And if you wish to share any more, please feel free. Any other comments from anybody else? Any questions?
And I think what I would comment in, Prof, is that what you said is so important. That, before you know that there is a relative of yours who has died or someone close has died from it, then people are not serious. They laugh at me when I'm doing all those kind of things here at my surgery, because they are saying, you are just maybe, are you okay in your head? Because, they think that I'm just joking. They have not seen anyone. We have close to maybe 200,000 or to 300,000 people living in this suburb, but none of them has seen anyone die from COVID. And that is the biggest problem. That, you know, we not convince people that someone has got a problem. Look at HIV. Everyone knows someone who has died from HIV, and people are, you know, are behaving very well. But for COVID, it's going to be very tricky until we have numbers like in South Africa.
Yeah, no, it's true. And I mean, our numbers in South Africa, it seems, are not high enough, even in Cape Town, to shift behavior that quickly, that much.
That's
So it may take quite a lot of, you know, we're probably going to get lots of more deaths before the curve shifts. It's going to be entirely dependent on people's behavior. So, Edward, you've said, you know, people have said you're mad to do all this. Are you actually having other GPs doing similar to you? What's the behavior of GPs, you know, amongst the broad population of general practitioners? Are they doing similarly to you, or is this your approach and not always shared by others?
I will talk anecdotally of 2 or 3 other practices where I have visited, and it's not as strict as I'm trying to do it here. It's a kind of a relaxed thing where people just check a temperature, and it's almost like business as usual. And I think that it's a time bomb which you are sitting on until one of us, some of us, start having the COVID from the patients. I think that will be the wake-up call. Again, the same thing like we're talking about the practice of the patients out there. Also, even the doctors have got that kind of attitude, despite all the education which we have.
Right. So is the conversation in the country now with COVID, you know, everybody's trying to push resources into hospitals, thinking, well, we need to prepare, you know, for the coming wave. And all they're thinking about is, you know, ventilators and ICUs, without investing the resources into primary care. Is that, do you think, also is happening in Zimbabwe? Or is there a sense, like you say, that no, it's the entire health system must be ready?
I must say this COVID has actually been a blessing in disguise for our health system, because it has shifted all the focus to our health system. And there is quite a lot happening now throughout, from the primary care to tertiary and quaternary level. So, well, it's everything has got a good and the bad side of it. The bad side of it is that it's an extra burden on the country, but the good side of it is that it has shifted everyone's eyes onto or right into the health system of our country. And yeah.
Well, that sounds great. You know, it's a conversation, I think, everywhere where health has become a big issue, where people are saying, no, we need to spend money on health because it has an economic consequence. Now they feel the cost. They realize not having good health is costly. So are you all, is that the kind of sentiment coming on?
The worst part is no one, even regardless of how much money you have, you can't go outside the country. You have to be treated in the country. So people just put their money where they stay. And, you know, that is the big plus of COVID.
Yeah. Well, that sounds good, because I think the conversation needs to be one that that enables us to highlight health issues. But now, what about primary health care? Do you think that the conversation around primary health care is growing, or is there opportunity to highlight the need for better primary care in the country?
Very much so. There is the good thing is our country has generally been primary health care focused. We have really been focused a lot on primary health care, although the resources were dwindling, but it has really made the government revamp its approach to primary health care. And you can see that even the wearing of masks, social distancing, all these things, it's primary health care, it's preventive care, which is very important in preventing diseases. Stop it before you get it. I think that's the message.
True. So is the conversation, I mean, I don't know whether you all in Zimbabwe have a similar conversation like in South Africa about universal coverage, new systems that move away from the current public-private sector sort of divide. Can you share a little bit of that conversation? Is that happening in, in Zimbabwe as well?
No, not yet, not yet.
Not yet. Okay. So is there any utilization of the private sector by government? Are they coming to the private sector to support the COVID response in some way, bringing the public and private together? Is that happening?
Absolutely, that has been happening, and it's something which has united everybody. You know, there's not a talk now about a private practice or public practice. When we are doing all the figures which you see about the testing and things like that, it's being done both in private and in public, and those are national figures which you are getting from everywhere.
Right.
So there's a lot of cooperation between the private and the public sector in terms of the health.
Sounds great. So is that not an opportunity to be able to talk about how going into the future for our universal coverage, that you could explore how the new health system can bring public and private closer together? Has there been any conversations in your cooperation with government?
I think it's something which we need to write down and take it up next time we're going to be meeting with the government.
Yes, no, I think that'll be excellent. I think that this, this difficulty or the challenge or the epidemic of COVID is not going to be a few months. It's going to be 2-3 years. And it could very well grow and become an even more challenging space for us all. So thank you very much, Edward. The idea in us meeting and talking is to share an understanding and to be able to find ways in which we could help strengthen primary health care across Africa, and also to be able to share what we can do differently to make that happen. Some of the conversations that we'd like to take forward as we're going along is, besides just sharing our responses to COVID, is to explore how we can build the primary health care team and be able to address universal coverage. And what are the challenges that we face in terms of organization of primary care, the human resource issues, whether management or development, and a whole host of other issues that we as clinicians on the ground have an opinion about and feel that we need to shape it so that it is very patient-centered and it delivers good quality, good value for our patients and for the health system. So I think there is one more question I see. John Musonda asks, I did not hear much about testing. What are the indications for testing? What are the challenges around test kits? I think you've mentioned it, but do you want to answer that briefly? We did talk about testing where you said you'll have gene experts, quite a few in the country, where your testing is in fact quite available, and that you'll have a 24-hour, almost 24-hour turnaround time. And I think you did mention that sometimes it's a little challenged. COVID testing, I'm not sure that I saw it on the data, but do you have an idea of how many patients and people have been tested for COVID in the country, for which you have your 500 people that have been identified? Do you have that?
We are nearly 600,000, 600,000 to 700,000 thereabouts. Yeah, maybe I will have to relook at the data for today. Yeah, 600 to 700. It's less than 10%. The positive cases is far much less than 10%. Yeah.
Okay, so it's about 10 times more. You got 500, so about 10 times more. And I think that Zimbabwe is probably one of the smaller breakouts in the continent. I don't think there are very many countries that have as smaller breakouts, so it's still relatively limited. But I think that your testing capacity would be something that you'd need to keep an eye on. But clearly, you're doing well for what you have right now. And we'll probably have to come back to Zimbabwe in a bit as we do these webinars to see how things have progressed and whether that things are all right or not. but most countries, the testing needs to be almost 100 times more than 10 times. Anyway, let's leave it at that. Thank you all very much. Appreciate that you've joined us. I want to say thank you very much to Edward, Dr. Chagonda. We really appreciate you spending the time with us this hour and providing all the participants, that are on board the opportunity to listen and understand what is going on in Zimbabwe. To all of you, thank you very much. Keep safe and enjoy the rest of your weekend. We hope to see you next week. We're hoping to get people from South Africa to share, especially in the Western Cape, to really share, especially being the hotspot within the hotspot of South Africa. And we're really keen to understand what are they doing on the ground to be able to do it. So thank you all very much. Enjoy your weekend. Bye-bye.
Thank you, Prof. Bye-bye.
Thank you, Edward. Bye-bye.
Bye-bye.